Panel is Compassionomics. And I'm going to start off by having the panel introduce themselves. We have a panel of very impressive people with lived experience, subject matter experts in this particular area. So I'll start with you, T.
Thank you. I'm Teresa Lamore Redmond. I go by T. I am a director of digital social innovation and health equity at Merck. My life is public health. I consider myself a public health practitioner. I don't consider myself an industry person. My background is in public health. I've worked in the field HIV, Hep C for many years before entering an industry. And I have the principle that I live by is that the more a person knows, the better they'll do. And I commit myself in this work to making sure that I want to play my part in making sure that we have as many informed patients as possible so that they're being a part of their treatment decision and they're making decisions from an informed place and not just taking what they're given from the HCP.
Thank you, T.
Hi, good morning, everyone. My name is Michelle Anderson Benjamin. I am a angel for Tiger Lily. I'm also the founder of the Fearless Warrior Project. I'm a certified mental health coach and advocate, a certified death doula, but I'm also a Black woman that was diagnosed with breast cancer at the age of 36 and currently living with metastatic triple negative breast cancer at the age of 40.
Thank you, Gina.
Hi, everybody. I'm Gina Wertenberg. I'm an associate professor at Rutgers Institute for Corporate Social Innovation, the Rutgers Business School. We support health equity in many different ways, and I'm really thrilled to be here and excited to participate.
Thank you, Gina.
Good morning, everyone. Brian Buckley, he, him pronouns. I kind of come with I guess, three identities as a pracademic here. First, the Director of Health Equity Initiatives at the National Committee for Quality Assurance, NCQA, where we lead measurement and accreditation development across the nation, but also as an assistant professor in medicine at the Georgetown School of Public Health, or School of Medicine and School of Health, where we actually teach medical students and health professionals around many of the topics that were actually in the first panel on partnering with community members, but then also come from that public health background as a board member of the American Public Health Association.
Thank you, Fatima.
Hello, everyone. I'm Fatima Scipione. I'm with Blueprint Medicines. I lead our patient advocacy efforts at that company, kind of like you, 3 roles. Prior to Blueprint, I was with Takeda Oncology for over a decade, leading our global patient advocacy group as well, and very much focused in multiple myeloma, where we know there is tremendous inequities with respect to care, and so led many of the efforts there to advance equal care, if you will, equitable care for our patients. I also worked in social services for many years in Boston prior to entering into the pharmaceutical industry, where I was part of the leadership for an organization called Lena Park Community Development Corporation. So certainly what we're talking about today is, I'm passionate about this topic. I want to make change. I'm an first-generation immigrant here in this country, and I've seen inequities from that lens. As I think of the care that my parents received, there were challenges around language. That was the inequity there, and led to a lot of challenges for my father. You know, my aspiration is that all patients have the skills, the courage, and the knowledge to navigate their healthcare journey so that they can achieve the best outcome possible, and that's all patients. So really delighted to be here. I appreciate the opportunity and looking forward to the dialogue.
Thank you, Fatima. Gina, I'm going to call on you first. I want to thank you, first of all, for bringing this topic to our attention and starting the conversation. Can you lay the foundation so that all of us are on the same page in terms of what is this concept, Compassionomics?
Absolutely. So before I do that, I just wanted to say, on a personal level, I was so moved by the earlier panel. In particular, I have a new granddaughter coming tomorrow, and she's on her way. I'll be hearing any moment. But anyway, what really touched me to the core is that I don't have to worry about those issues. I mean, it's like so unfair. It's so profoundly the discrimination and all the racism, and I know it exists, but I really, having it be personally affecting me and seeing that, it's like really upsetting. Anyway, thank you for sharing. Compassionomics. So a couple of years ago, I had the opportunity to come across this book, which some of you, including Brian, have read, Compassionomics, the Revolutionary Scientific Evidence That Caring Makes a Difference by Stephen Treziak and Anthony Mazzarelli. And in this book, they summarized 1,000 studies and 1,000 abstracts and 250 studies showing the irrefutable, overwhelming, measurable, my buddy measures, evidence that human connection, caring, and compassion actually makes a difference. It makes a difference in patient outcomes, provider outcomes, organizational outcomes, financial outcomes for hospitals and medicine. So what are a few of these outcomes? First of all, in terms of doctors that show compassion, it reduces stress. It lowers blood pressure. It reduces perceptions of pain. From a perspective of psychological, it helps to alleviate depression, anxiety, distress, from dealing with the unbearable and making the unbearable bearable. And then you might wonder, what about financially? How does it affect financially? We are in business, many of us. So basically, it drives revenue and reduces costs in a number of ways. Number one, hospitals that perform better have reduced costs, okay? Patients, there'll be fewer malpractice suits, fewer errors, better adherence, et cetera. And it will cut employee absence. So the bottom line is human connection matters. And I really like the comment that was made earlier about training. Training really matters, and it does make a difference. And the training that occurs right now is extremely insufficient. And also, what we learned, it's often racist.
Thank you for that, Gina. And putting this out to the panelists, well, what does that look like? What does compassion look like in this? We use words like trust. We use words like the human connection. Can folks talk a little bit about other concepts or, you know, your experience, your lived experience of what that looks like?
Okay.
Michelle, thank you.
So I have metastatic breast cancer. So I go to, I'm in a clinical trial. I go to treatment every 3 weeks. But what compassion looks like is having that connection and that relationship with your medical team that you are more than just a patient. And it starts from the very beginning. It starts with your doctor speaking to you outside of just your medical needs. What does your family structure look like? What is important to you? What are your goals? What are the things you want to accomplish? Because at the end of the day, living with an illness doesn't stop life. You still have to live. You still have to be a mom. You still have to work. You still have to live. So this added component, it doesn't just erase those things. It still matters. So for myself, my medical team knows I'm a mom of two. I have a 17-year-old son and a 7-year-old daughter. My daughter is very active. She's also an advocate in this journey as well, but their activities are very important to me. So my treatment and my appointments have to work around their schedule, not my life work around my cancer journey. But also what are my goals? I just turned 40 last month, and I am intentional to live my life out loud. So I come with my schedule of these are the dates that I have trips planned. We have to work around this schedule, but that matters to a patient because it's more than just our medical needs. It's our mental and our emotional. In order for patients to show up, they have to be mentally and emotionally ready, and their mindset has to be in that place. And it takes a lot than just, this is the drug you need to take. You have to come to this appointment on Monday, Tuesday, Wednesday, Thursday, and Friday, and you'll be here from 9 to 5. Those things matter. And having a medical team that listens to you and not just talk to you matters. So, encouraging patients to speak up for themselves. Everyone cannot advocate verbally, but there's other methods of advocating. You can, Tiger Lily has a barrier toolkit where they have a list of questions. Patient might not be comfortable actually speaking, but you can send those questions to your doctor on the portal. You can hand it to them at your appointment and say, these are some of the questions that I have about my care. Is it possible you can email me the answers? Or bring a family friend or someone you trust to come with you that can be your voice. Ways of advocacy is so many different methods, but it starts from that initial conversation of when you have a conversation with that patient and say, unfortunately, you've been diagnosed. Let them know this is an open space. This is a safe space for you to ask whatever you want to ask, and no question is wrong, because it's not about just your illness. It is about you, the person.
Thank you for that. Thank you for sharing your story, Michelle.
And I'll build on that too, because I think we've kind of talked about in the earlier panel about this idea of trust. And actually, I've always told people it's not just trust is the outcome, but how are we as organizations being trustworthy? And I think that speaks to a lot of what you said, even the shift as we've seen in healthcare, going away from patient-centered care to person-centered care. I want to make sure I'm not just this thing that you feel like you need to fix, but I have this whole entire life. I'm spending most of my life outside of the four walls of a hospital or outside of an office. And so I think to your question about what does that look like in practice, it looks like listening. We talked about active listening before. One of the things, tools that ARC has created was even the what's important to you, just taking 2 minutes to just listen to the patient, not try to get ahead, I already seen your chart. I think I already know what's wrong with you. But actually understanding even those small little conversations, it's not just with the doctor, but everyone throughout that whole entire patient journey, whether it's the person that is signing you in, a nurse, a discharge planner, community health workers that are building trust within communities. That's what it looks like. Even aspects of, I don't know, I'm sorry, let me take some time to look into this more. Understanding, one of the things that we talked about in the first panel was the idea of how do we get to this point of cultural humility, I think is really this idea of curiosity, understanding where are you from in the DC area. If you tell someone, hey, I need you to get fresh fruits and groceries, if they're in Southeast DC, they may not have access to that very much. And so are you even aware of where they actually live and the resources that they have? Or if you're gonna make a medical appointment, knowing it might take 8 buses to get to that medical appointment, that's what it looks like to have compassionate care.
Thank you for
Can I
that,
just
Brian.
add to that as well? I think we're in a place where our doctors' practices are really busy. They don't have time, and it's not an excuse. And so in my role as advocacy, it's how can we envelop and support the person who's going through this experience with the advocacy that's out there. So certainly I agree, listening is absolutely critical, and listening versus having sort of a thought in your head already. But I think about Tiger Lily, and I think about the advocacy community that's doing tremendous work and should be considered a partner in this ecosystem, and looking to our physicians and our practices to say, advocacy is your partner. They can reinforce a better experience for the patient. They can provide services, to your point. You know, if it does take 7 buses to get there, there are groups like Triage Cancer who can help with that, who can provide the ability to get the patient to the practice or to think about second opinions. I think we need to think about the ecosystem, and how are we partnering together to help the patient in the situation that they're at, whether they're hearing they have cancer, and what comes next. Because I do know, I've sat in some of these practices and I've waited for nurses who are, it's 10 o'clock at night and they're still charting. And so you have that element of the practice being overwhelmed with what they've got going on now. So how do you stop that cycle? How do you support the practice? How do you support the patient in the ecosystem that's available here in the United States? Tiger Lily does amazing work. I'd love to see that any woman who is diagnosed with breast cancer gets connected to Tiger Lily, because they'll receive additional support, guidance, how to make those office visits more successful, more productive, answer their questions, but then bring in the practice too with Tiger Lily and create a community that's really supporting the patient.
Thank you, Fatima. Another subject that I'd like to touch upon is, okay, we know some concepts as to what compassion looks like. However, can it really be taught? The last group of panelists spoke explicitly about the role of medical racism leading to poor outcomes for Black and brown folks. So with that level of toxicity that we've been living with from 1619, even probably prior to that, and I went to a training by a neurologist from Harvard who even said that racism imprints. It becomes generational. It actually imprints on your DNA. That's what neurologists are finding in the science. So if that is the case, can you teach active listening? Can you reduce unconscious bias? Is it possible? Weigh in.
I think it is possible. I feel as though we talked about active listening, talked about creating that community, but it's also about giving them what you don't know, you do not know. And it's an opportunity to educate. And so there's an opportunity to provide providers with those skills, with the information to help them realize that the way they're communicating with their patient may not be working right now, right? And so giving them those cues around culture, around just regional. You just talked about, getting fresh fruit in a particular region. They may be in a food desert. So we should be educating the provider about understanding what's around them, where they're practicing, what their patients are. And then that way they are able to change the tone of their conversation. And just doing a little bit at a time will take you further. And so you just have to power them with the tools. And I think that's where we play a role. Don't always assume that they do not want to, because most times they'll say, I don't know. And if we bring that to their attention, more than not, they're going to be willing to embrace and try to change, because they want the best for their patient as well. Mm-hmm. And we know they're empathetic already, right? They wouldn't be in their field if they did not care about their patient. So we just need to be their partner in that care journey.
To also add to that is also that both parties have to be open-minded. Just a personal experience for myself, my oncologist, when I went from stage 1 to stage 4, and in one of my appointments, my oncologist broke down. And, me and him have always had a good relationship. We've had fights, back and forth about my care, but it was respectful and, we were real. And his breakdown was because he was frustrated with the fact that when I was first diagnosed, we did the most aggressive treatment. My treatment went well. I didn't have any issues with chemotherapy. And everything went well, and I went into remission. And then 6 months later, I had stage 4, and he felt that he failed. And, he's like, and even when we had that conversation where he had to tell me that, I had my breakdown for about 5 minutes, and then I lifted my head up and was like, so what are we going to do about it? Mm-hmm. And what he got from me, and he said, one thing you've shown me is that living your life out loud. Life is going to constantly hit you with barriers and obstacles. How you show up for those things is what matters. And, you speak your mind, but you also listen to what I have to say, and we respect each other. And he goes, you as a patient have changed my mindset of how I look at metastatic breast cancer. Because we have this in the medical world, we try not to use the word terminal, right? And then they don't know if to say the word stage 4, impacts the patient and makes the patient feel a certain way. So they're always trying to find words that cannot hit to the core. And then, for me, like I told him, when you change the word curable to quality of life, that's a real blow to a person, especially like myself. But it also shows what is quality of life. How are you showing this patient that their quality of life matters? Because I know your role is to give me medicine to keep me here longer, right? But what am I doing in that time that I'm here? How am I living my life still? How am I accomplishing my goals? How am I, doing my bucket list? How am I leaving a legacy for my children? How am I creating generational wealth? How am I teaching my daughter, who is now 7, who has to have mammograms at 25, that her life matters, and educating her about herself? All those things matter. So as he felt by me being that type of patient, his mindset is different of how he deals with his other patients. He's having those conversations about, what do you aspire to be? What are your goals? What are some of the things that you want to achieve in your life, and how can I help you get there? How can I connect you with organizations that can help you? I might not have all the answers, but I can help you I can get you in the right direction. And those patients in turn show up. They come for their appointments. They show up for their treatment, because at the end of the day, they feel that they're loved and they're needed, and they're in a safe space. So it's bigger than the medical part of it. It's the mental and emotional component that has to be in play at all times. And when medical teams and patients are connected in that way, that compassion stays. And the quality of work they give is much greater, because they're doing it out of love.
Thank you. Yes. Thank you.
I have an example, Terry. So one thing that the International Myeloma Foundation did was start to work with fellows. Start with and talk about compassionate care, and set those expectations in place really early with fellows. And I think they've had a lot of success. They're creating a community of physicians who care differently, who listen differently, who understand the compassion element, because they're exposed to someone who's living with multiple myeloma really early. So I really appreciate what the International Myeloma Foundation is doing with fellows. I think that's tremendous, and I'd love to see that across, frankly, all the diseases.
Thank you for that.
I guess to add to that, some of the work that we're doing at Georgetown, to your point about can it be taught? Yes. So I think aspects that we are doing is, one, how to receive feedback. And that's actually a big one. How do you receive feedback from your patients? Because you should always be on a journey of learning, not just from your peers, which often many providers do, but learning from your patients. 2, also teaching cultural humility and understanding what active listening looks like, creating some techniques around that. And 3 is really, it's called Go to the Gemba Lean principle, but actually go explore communities. So one of the things that our medical students do is partner with community-based organizations and actually volunteer there for the whole entire year. So the one that I work with and preceptor for is an organization called Food and Friends, which creates medically tailored meals with people with chronic health conditions across the DC area. And they actually go out on delivery of foods, see where people live. One of the things I ask them to do is count how many grocery stores you see what people are saying. Just be able to be a human being and converse with them and say, hey, thank you. How are you doing? Is everything okay? Anything you need me to take back? So even just that ability to, one, ask for feedback, but then also collect it. Those are some of the skill sets that I think many providers, and it gives me hope that a lot of the new generation of physicians are starting to have that mental model, starting to understand what systemic aspects of oppression actually look like in healthcare, and looking at not just that, but also teaching them advocacy skills. Because to your point before, doctors don't really have a lot of time. That's a core problem we need to actually fix. How do we get to more value, patient-first payment system that allows doctors and other providers to truly have that time with their patients, to make sure that they're looking at them as a whole person.
Thank you for that. And what I'm hearing from the panelists also is that we're not just looking at compassion in terms of an individual or several individuals, but it's a team. You use the word team. It's an ecological issue. It's a team sport, if you will. So just to tell a story so that we can start talking about what these care teams look like, especially my area of interest in addition to HIV is oncology. My mother was diagnosed with cancer 2 years ago. She has since passed. I took a year off. I took a sabbatical to go, back to my hometown of Baltimore to take care of my mom. And I knew I had to do that because when I first met with her team, and the team was the oncologist and the surgeon. And I come from a background, I am a practitioner also. I work in industry, but a practitioner, boots on the ground in public health, in Black and brown communities who are low SES. Criminal justice system, that has been my life's work. And when I did not see a nurse at that meeting, and when I did not see a patient navigator or a peer in that meeting, I turned to my father and I said, Dad, I'm coming home because this is going to go sideways. Mm-hmm. You will never be able to get the information that you need in a health literate way from this oncologist and this surgeon. It's not going to happen because I know what good looks like in HIV. I know what it took in the early 90s, that's where I cut my teeth, to lift and to say, we demand compassion. But there was connective tissue there, LGBTQ communities, Black communities, here are our demands. We know what good looks like. What are you've worked in HIV, you have a powerful story about where your advocacy came from, Michelle, and that I hear you use words like, I'm not a victim, I am a thriver. I'm more than a survivor, I am a thriver. I have quality of life. This is who I want to be as long as I'm on this earth. Let's talk about that.
A lot of lessons can be taken from the HIV community. And that's where I started my advocacy work in non-for-profit. And that's the model I use as I work in oncology now, is that there are so many learnings and around the care team and the importance of having a supportive care team in for an oncology patient, just as for any patient in general, right? You should really have a care team because the provider is one part of the story. There are so many things that an individual is dealing with when they come in to a provider for care. They have their entire life outside of their diagnosis that they are now trying to navigate, and they need help because that's the only way they can be successful on treatment. Mm-hmm. So when we talk about a non-adherent patient, it's not necessarily because they don't want to. It is because they do not have all the tools in place, and they are trying to struggle, especially for women, Black women. They are the primary caregivers in the home. The data supports that. We have one sitting right here in front of us. This is who we need to support, women like Michelle, because they need every aspect of their life put together so that they can be on treatment. So when you provide that care from a holistic place, and like you said with your mother saying like, okay, who's going to have this conversation? They receive that medical information. The patient does not know what it means. So you have to be able to break it down to them. And sometimes, and we can't always say it's the provider's responsibility. They don't have the time, and we have to be realistic about it. So build them a team that can help them, providing resources. That's what we do. We recognize these barriers, and we're looking at it from a place of, if these are the barriers in place, what can we do from an industry perspective to help not only the patient, but the provider so that they now can have the tools in place so that they can start their treatment and stay on their treatment?
Thank you, Tay. Really appreciate that.
I just want to add to that. So prior to, I work in healthcare as well. I've been working in healthcare for 7 years. But prior to that, I was a manager in retail banking. And I always live by the model that you treat people as you want to be treated, regardless of what your title is, right? And oftentimes we get into positions where we have this entitlement where we feel like we have to talk down to people and not talk to people as our equal. And one of the things I always encourage other patients is to ask their doctor about their family, how, their parents, right? Sometimes we have to change the conversation just from a medical perspective and make it more personal, because that shows the person that you are a person. You're not just a patient. But you have to have a medical team that is willing to also open up that door on the receiving end. And once you start doing that, those conversations become more of a relationship, and not just an interaction during medical treatments or medical appointments. When I was going through my journey in the beginning, I would ask my doctor, would you recommend this to your wife? Would you recommend this treatment to your wife? Would you have your daughter go through this if she was in my position? And if you couldn't give me a firm answer, then we're going to have to research what you're talking about more before we go through it, But I also let them know, I am a mother and I have 2 kids and my kids don't play about me. So I need you to remember that when I would walk in the surgery, I would have them play music. I would speak to everybody in that operating room and let them know I have 2 kids that are waiting for their mother to wake up.
Yes.
So when you're working on my body while I'm asleep, remember that you got 2 kids that you need to answer to, because they don't play about their mom. And even with my daughter is 7, and unfortunately I was diagnosed during a pandemic where there were so many restrictions and family could not be a part of things. And once things started to lift, I had a conversation with my doctor. I said, my daughter been trying to get in this hospital since day 1, and she needs to see you face to face. She has questions she needs to ask, and she's determined to get them done. And they agreed to allow her to come in, and sis came in with her badge on. She made her own badge. She had her own notes, and she went and she met with the research team and the nurse. She met with everyone, but she wanted them to know who she was. And she had her questions. Does my mom listen to the instructions you give her? How is she as a patient? But these are things that, as medical teams and the whole team, not just oncologists, needs to understand. That is how you build relationships with your patients, because it's not just the patient. They have a whole family behind them that has questions, that want to be involved. And you have to also know that you're not just dealing with them, you're dealing with a village.
Yes.
And you have to love on the village, and the village will love on you back as well. They will make sure that at home that patient is getting the support they need to show up for those treatments every Friday. Like, I have to go this Friday. They will make sure that that patient is taking their medication when they need to. They will make sure if that patient is not looking good, they know who to call. But it's much deeper than just that interaction. Just because they're your patient, you have to always remember that they are a person.
Thank you so much for that. As I've been given the signal about wrapping up, but as we wrap up, just some thoughts, because I know that there are a lot of providers in the audience. Some of you are prescribers, surgeons, whatever it may be. I mean, really listen to the panelists. It's like what I've heard on the panel is, compassion looks like asking your patients about what brings them joy, who their families are, how, what their families do, how they love each other. It's like, once I was up at Montefiore Emergency Room, which is just crazy in New York. Mm-hmm. And when you're in the emergency room, here's what love looks like. It's in the Bronx, the brownest borough, that I live in New York. And it's a family affair. You see families going out getting rice and beans, and we're there. Yeah. We're there. That's what love looks like. And those who have worked in that hospital for years, they get it and they know it. So thank you so much for sharing your stories and insights. Yes.
It's my charger. I just didn't want someone to lose their phone.
Oh, I'm going to put something on the box.
We're gonna do our little moment. Yeah, we're like, do our moment. But it's gonna be a bathroom break and all that stuff. So if you want to head out, we just don't repeat. Wow.
many ways, so many levels.
I'm gonna guess. I'm gonna use my Instagram. My daughter, she likes vlogs. I'm gonna come talk to you after this. There's Chloe as well. Yes, everyone knows all that. She's called Joe, and she teaches. Yes, yes, she teaches. Yes, yes.
I'm sorry, can we scoot you all just straight over this way?
Thank you.
Hey, awesome. I thought you were coming so late. Oh, all right. You got to be on. Oh, okay.
You're with, are you in this?
Yes. No.
Yeah.
No, I'm leaving this session.
Okay. Let me go get,
Yes.
Oh, we met each other, I think.
Okay.
No, the blackboxes.org
Yeah.
ceremony. What was it?
Yeah, Top Blacks in Healthcare.
Sorry, you want to see me?
Yeah. You know, it's an acronym for everything. Yeah. All right. Who wants to do? Thank you.
All right.
All right, ladies and gentlemen, we are continuing on today. Wow, what a panel. What a fireside chat. What an incredible showcase of not only information, but compassion. Oh man, thanks so much for everyone being here today. Jade, you had a couple points.
I did. I think the key point that I pulled away is listening to your patients, seeing them as people, seeing them for who they are, asking questions. What are your goals? What are your passions? How's your family? Seeing them as a human being and then being able to provide them the care that they need.
Yes, one quick point that I want to bring out is one of the panelists, they said, life is going to hit you with all sorts of battles, but it's the fact that you keep showing up every day is what really matters. And that's what you all have done here today. You all have shown up, even though you have so much going on in your life, you all have shown up today. So we want to give yourselves a round of applause today as well. So with that, we want to cut this real quick. We're going to give everybody 5 minutes just to use the bathroom, check your email, do stuff like that. We'll convene in 5 minutes. Thank you.